In a newly diagnosed patient with type 2 diabetes, the physiological environment is already highly compromised. Under extreme metabolic stress, the pancreatic beta cells, responsible for insulin production, rapidly lose their structural integrity and fail. Because of this severe loss of beta cell function, driving these patients back to long-term normoglycemia, defined as an HbA1c below 7%, is exceptionally difficult. Historically, statin pharmacological therapies targeting a single metabolic pathway have struggled to reach this threshold. The Phase 3 Surpass clinical trials disrupted those clinical expectations, presenting a pool of data that required a reevaluation of expected metabolic outcomes. This chart aggregates the clinical outcomes. Looking at the mean reduction in HbA1c across the Tirzepatide cohorts compared to the placebo baseline, we see an absolute drop of 1.93. Here, the contrast is even starker. The cohorts averaged a reduction of over 6.63 kilograms, scaling heavily into double-digit kilogram losses at higher dosages. Achieving these clinical efficacy metrics requires a reassessment of the mechanistic approach to incretin therapies. For years, the clinical benchmark for glycemic control has been Semaglutide, a highly effective, pure GLP-1 receptor analog. This bar chart sets Tirzepatide directly against Semaglutide across a 40-week timeline. We are looking specifically at the HbA1c endpoints. Even at its lowest 5 mg dose, the new drug achieves an endpoint of 6.19%, outperforming the established active comparator. The data reveals a distinct mechanism of action. Tirzepatide operates as a pharmacologically distinct class of dual glucose-dependent insulinotropic polypeptide, or GIP, and GLP-1 receptor agonist. Instead of isolating one pathway, a single synthetic peptide is engineered to engage two separate cellular receptor sites simultaneously. The superior clinical outcomes emerge from a specific shift in the architecture of peptide engineering, rather than simply increasing a standard chemical dose. To understand the structure of a dual agonist, we have to look at the central pharmacological hurdle of all incretin therapies: survival. Native peptides are rapidly degraded in the bloodstream by aggressive DPP-4 enzymes, leaving an extremely short, unviable half-life. This diagram illustrates how Semaglutide solves this pharmacokinetic problem. The baseline amino acid sequence is heavily modified to resist enzymatic cleavage. Notice the C18 fatty acid chain fused directly to the sequence on the left, allowing temporary binding to albumin. Other drugs approach the survival problem using sheer mass. This is the structure of dulaglutide. It fuses GLP-1 analogs directly to a heavy immunoglobulin G4 fragment to restrict renal clearance. But single-target approaches hit a biological limit. Escalating the dose to force further glycemic control eventually meets a hard ceiling of severe, intolerable gastrointestinal side effects. Pushing pure GLP-1 monotherapy to its maximum uncovers a biological boundary. Driving blood glucose lower safely requires an entirely new structural blueprint. This is the complete 39 amino acid sequence of Tirzepatide. Look closely at positions 2 and 13. These non-coded residues act as structural shields, physically preventing premature degradation by DPP-4 enzymes. At position 20, a C20 fatty acid chain acts as the critical anchoring modification. This extended lipid chain drives high-affinity binding to plasma albumin. Once injected, 99% of the drug circulates in a bound state. The result is a massive 10.3-liter volume of distribution. This drastically slows the rate of clearance, extending the drug's half-life to 5 full days and enabling a single weekly subcutaneous dose. By anchoring a smaller therapeutic peptide to a massive blood protein, the molecule successfully evades rapid renal filtration. These molecular modifications prioritize pharmacokinetic stability. By resisting enzymatic breakdown, the dual agonist persists in the circulation, maintaining the necessary concentration to engage with pancreatic and neural targets. However, the most critical design feature of Tirzepatide relies on a deliberate imbalance. It is a dual agonist, yet its interaction with its two target receptors is highly unequal. We can analyze the mechanism by looking at the two target sites side by side. On the left, the drug binds with an affinity equal to the body's native GIP hormone, achieving full potency and mimicking endogenous activation. But on the GLP-1 side on the right, the connection is much weaker. The peptide is engineered to bind with only 1/5 the strength of native GLP-1, reducing actual activation potency to 1/13. This severe asymmetry relies on a specific clinical hypothesis. The drug leans heavily on the GIP interaction to maximize synergistic glucose-dependent insulin secretion. The reduced GLP-1 affinity acts as an intentional physiological throttle. By limiting GLP-1 overactivation, the drug avoids triggering the severe nausea and vomiting historically linked to maximum GLP-1 stimulation. The asymmetric binding profile is an engineered choice. It breaks through previous efficacy ceilings without causing an uncontrollable rise in dose-limiting side effects. Moving from the molecule back to clinical reality, we find that even with an affinity throttle, gastrointestinal tolerability remains the primary bottleneck for treatment. This chart aggregates the incidence of the 3 major gastrointestinal side effects compared to a placebo baseline. Nausea at 15.4% and diarrhea at 17.8% emerge as the most prevalent issues driving treatment discomfort. Adverse events scale tightly with the administered dosage, as shown in this dose-response breakdown. Look closely at the maximum 15 mg cohort. We observe a distinct spike, peaking at 22 cases of nausea and 17 of diarrhea within the trial group. To mitigate this, trial protocols mandated strict dose escalation regimens. Patients were required to step up their dosage in 2.5 mg increments over multi-week blocks. The trial data proves that enforcing physiological adaptation over a slow, stepwise timeline is a prerequisite to safely harnessing this level of glycemic control. For clinicians managing advanced insulin resistance, these results shift the baseline expectations for non-surgical intervention. Therapies must now be evaluated against a new standard: double-digit kilogram weight loss and HbA1c reductions approaching 2 full %. This dual receptor metabolic correction reverberates across the broader cardio-renal metabolic pathophysiology of type 2 diabetes. Sustaining normal glycemia over an extended period of time allows chronically inflamed metabolic organ tissue to slowly resolve, fully restoring proper cellular function. By moving past single receptor pathways, Tirzepatide demonstrates that precision-engineered dual agonists provide a viable path toward metabolic outcomes previously reserved for bariatric surgery.